The American Brain Tumor Association is pleased to welcome you to our webinar series. My name is Bree Salzman, and I'm a program manager here at the ABTA. As a quick disclaimer, the American Brain Tumor Association provides this information as a service. Information provided by the ABTA is not a substitute for medical advice, and a diagnosis, treatment, or other healthcare services. This information is not intended to replace discussions with your physician, and the ABTA strongly suggests consulting with your doctor or other healthcare professionals regarding your particular needs. That said, I'm really looking forward to today's topic, facing a brain tumor recurrence with resilience. Our speaker today, Dr. Alex Porter, is a professor of neurology and the director of neuro-oncology section at Mayo Clinic in Arizona. Having been with Mayo for over 2 decades, she's worked diligently to provide care for patients with tumors and cancers involving the nervous system, in addition to patients who have neurologic complications resulting from their systemic cancers. Her research interests are aimed at ensuring that patients with brain cancers have the best quality of life possible. And to this end, she is co-author of the book, Navigating Life with a Brain Tumor, a resource for patients and families, which I know she will share more about in today's webinar. In addition, Dr. Porter was the 2020 recipient of the Dean's Award for Diversity and Inclusion for the Mayo Clinic Alex School of Medicine and the Ann B. Young Diversity Scholar Award with Massachusetts General Hospital for her work in equity and inclusion. She was recently recognized as 2023 Alumni Emerging Leader from the Lewis Katz School of Medicine at Temple University. And if that's not already impressive, she is noted to be a top provider by the Mayo Clinic Office of Patient Experience for the last several years, and Castle and Conley Exceptional Women in Medicine. We are so thrilled to welcome her to the conversation today. Thank you so much for joining us, Dr. Porter. I'll let you take it away.
Wonderful. Thank you so much, Bree, for that generous introduction. I can't imagine a place I'd rather be than spending some time with the ABTA community this afternoon. I bring you greetings from Phoenix, Arizona. It's a sunny day today. What's happening with the weather is not lost on me after spending 5 winters in Minnesota. I get it. And my son is enjoying a snow day from school living in Maryland. So for all of you that are digging out, my thoughts are with you indeed. But for the next 40 minutes, we have an opportunity to what I hope would be really a conversation around how to navigate some of the challenges that come with having a brain tumor diagnosis, recognizing that everybody's path and everyone's journey looks a little bit different. But there are ups and downs along the way. And how do we face those varied ups and downs with some tools that can help us build some the word that we're using today is resilience, but how do we have some tools that we can take along with us to really help us approach those ups and downs with some education, which for me, in my goal of advocating for patients and their families, I recognize that the education often is the first tool, a first key to having that empowerment to be able to move forward. So we'll talk for about 40-ish minutes or so, and then there'll be an opportunity to answer some of your questions. And so I'll start by sharing some of the learning objectives for our time together. We'll talk about some of the key medical aspects as it pertains to brain tumor recurrence, which also includes some treatment options, goals of care, and I'll have a kind of a list of broad topics that you should be ready to ask your healthcare team as it pertains to recurrence. I also recognize that there are so many emotional ups and downs that come with this journey. And so recognizing them up front, normalizing them because this is part of the experience, and really helping to all of us understand the psychological impact that recurrence has not only on patients, but also caregivers and all of those folks that are part of your support system. We'll talk about some practical coping strategies to build that emotional resilience when facing a recurrent diagnosis or the fear of recurrence. And, oftentimes when you hear the word resilience, we can think that that means that we're just supposed to bounce back unaffected. But really, when we look a little bit closer at what resilience means, it's that adaptation. How do we have some practical strategies to help us adapt when we hear about recurrence, regardless of the tumor type? And then how through this education, how can we then feel empowered to be able to communicate and ask those questions that are so critical to have answered to help us navigate what the best next step for each of us along this journey might be? Recognizing that our families and our support systems care deeply, and we need to be able to communicate very openly with our healthcare teams about some of the fears we might be experiencing, what we need. And sometimes the question to the healthcare team is, I don't know what I don't know. Help me know what I might need for this next step. Those are the sorts of questions that ultimately lead to that empowerment to help us navigate on this journey. So as we jump in, I thought we might try to level set a bit and talk about what recurrence actually means. And I recognize that with the number of people that have joined us for this webinar today, that there might be folks who have experience with all different types of brain tumors. So this could range from folks who have seemingly benign tumors or non-cancerous tumors. So I'll give an example of a grade 1 meningioma. We may have folks that are engaged in our session today who have the most malignant or aggressive of brain cancers, like glioblastoma. But anytime we're talking about recurrence, what we mean is there appears to be activity, growth of a brain tumor after treatment. And treatment could be surgical resection. Treatment might mean radiation or chemotherapy. But the idea is this recurrence is the return of the brain tumor after treatment caused by residual or new tumor cells. So in many instances, the first step in managing a brain tumor is a surgical resection. And so in some cases, only a portion of a tumor might be able to be removed. And in that case, you'll say that the portion that remains is residual. Now, that residual tumor might be silent or inactive, or that residual tumor could then grow following the surgery. That would be called a recurrence. Or say you're in a situation where an entire tumor has been removed and there's no evidence of any residual tumor. And then you have some form of treatment. Sometimes we can see regrowth or recurrence or tumor activity within months. Sometimes we can see recurrence or growth within years. In rare situations, we can see recurrence or growth within days. And so as I try very hard to sort of meet the needs of this very diverse community that joins us today, recognizing that recurrence can look a little bit different for each tumor type, but it really does depend on how well those initial treatments, whether it be surgery or radiation or chemo or targeted therapy, how well each of those things worked, and then the recurrence can absolutely depend on the exact tumor type. So as we dig just a little bit deeper, and we think about some of the signs and symptoms that we need to be sensitive to, I always suggest to my patients that I will never give them an exact list because I fear that some symptom will come up that's not on the list and they won't call me because I didn't write it down. So I'll tell you that for those of you who have been to the doctor's office recently, there's something that your provider will engage you in, which is called a review of systems. And so they may go through a list of symptoms, and I tell people we're going to go from top to toe. You tell me yes or no. Have you had any new or different headaches? Are you having any changes in your vision, specifically? Any double vision, tunneling of the vision, losing vision in either eye? Have you had any numbness, tingling, or pain anywhere in the face? Trouble with your hearing or hearing loss? Any vertigo, like things are spinning? Have you had any change in your swallowing where it's going down the wrong tube or coming out of your nose? Have you gone weak or numb in either arm or leg? Any changes in your walking or balance? Have you had any episodes where you've lost consciousness or concerned anybody for seizure, concussion? Are you having any difficulty with your thinking or memory or language, getting out the words that you want to say or understanding the words that are being said to you? This, what I just went through, is a neurologic review of systems. And if any of those symptoms turn to yes, those are the things that you need to be sensitive to. And those are the things that you need to reach out to your provider to inquire more about. Not everything that you may experience could be attributed to the tumor, but certainly important for you to let your provider know so that they can help you with that differentiation rather than the automatic assumption of, oh, this means that there's a recurrence. So we do know that if you had a certain set of symptoms that led to your original diagnosis, those symptoms returning could be an indication that recurrence has happened. And so certainly important to keep track. Some people choose to use journals, keeping track of some of their symptoms. Some people do it through their iPhone or their smartphone. But the truth is, if there's any change in your typical symptom pattern, or if there's something new that comes up, that's something that's important that you bring to your provider so that additional evaluation can be done. And so, as we talk about the different phases of tumor treatment, cancer treatment, there are a couple of different times in the journey that are important to define because ultimately what that means is different treatment options certainly could come available, clinical trials could become available. And so important that you understand primary diagnosis is the first time that we end up identifying that you have this tumor. And then recurrence is if the tumor grows back after the initial treatment. And so we know that sometimes recurrent tumors can behave in a more malignant way than they did the first time. We know that because the tumor may have a more aggressive behavior or may have new sort of genetic mutations, this might impact treatment. And so one of the things that one of the studies that had been published in the last couple of years looked at brain metastases from different solid organ tumors. So whether you've got a lung cancer or a breast cancer as an example that then travel to the brain. And if you look at the type of cancer that was resected, say, from the breast or the lung, and then you look at the tumor that was resected from the brain, in many instances, the genetics may look different. And so that potentially could open up other targeted therapy options. And so that's what we mean when we say impact on treatment. And then the importance of understanding where you are in your treatment journey from primary diagnosis to recurrence is also important to understand how that might impact prognosis. And so I will talk a little bit more about this as we spend more time together, but I'll share it with you that to me and in my practice, prognosis ends up being an ongoing discussion. It's I feel like we've not done our patients a service if we don't talk about prognosis until it seems like we're at the very end of the journey together. It's something that should be talked about early and often because things continue to change. And the more we're able to normalize that conversation, the easier it is to then be able to develop some of that resilience as we hit the different bumps in the road, hoping they never come, but at least we'll be more prepared to be able to advocate in a way that's empowering for our patients and their families. And so there are a few things that are critical to the physicians, your care teams, as we start dealing with recurrence and help you reach the goals that you have for your life, for your well-being, recognizing that care goals can shift at different parts along the journey. There are patients that I have been privileged enough to walk alongside who tell me that they have a goal of taking a cruise to some beautiful place. There are others that tell me that their desire is a grandchild's graduation or a wedding or something like that. Understanding each of our goals and each of your goals ends up being critically important to how we approach recurrence. And again, all of this does depend on tumor type. But I have a patient as an example who has a pituitary adenoma. And a pituitary adenoma is located sort of at the base of the skull. If I were to draw a line in between my eyes and just above my ear where it meets up in the middle, it's a deep part of the brain, can be difficult sometimes to access to remove the tumor in its entirety. And the challenge that this particular patient was facing was in regards to their vision. And they have a child, they are the primary driver. And so the discussion that we had is we can do whatever we need to do, but I can't lose my vision. I can't have any visual impact. Critically important for me to know, right? Or for someone whose job requires them to type or use the keyboard, and now the recurrence of whatever tumor they may have impacts the function of their right hand. Important for us to understand how that impacts life so that we can talk through what other supportive sorts of services we might be able to use to help empower and help really support as at the highest level of independence as possible. So as you are facing a recurrence, regardless of the tumor type, symptom management focus is going to be the first priority, really with an emphasis on quality of life and developing a care plan that is going to be appropriate for you. We do not, there are some tumors where, unfortunately, we have not yet evolved enough in the science where we can truly personalize the care. And so in those tumor types, we might say, okay, everyone with this particular tumor receives chemotherapy and radiation, and that's what we have for you. Where we'd like to be is a much more personalized care plan. And so, and what that requires is to take a look at the tissue, understanding some of the genetic abnormalities that are within your tumor and say, okay, based on what your goals are, what your lifestyle is like, maybe we might consider drug A, B, or C. And maybe we might be able to hold off on radiation for a time, or maybe the conversation is the opposite. But having these conversations about being able to meet your needs or reach your goals based on focusing on symptom management, quality of life, and a personalized care plan should continue to be at the top of your mind. And so if you've got a pen and paper with you or you want to take a screenshot, these are some of the key questions that you would want to discuss with your healthcare provider. Number one, what are my treatment options? And so sometimes the treatment options are FDA approved. These are things that are well covered by insurance companies. There's strong data to support their use. Sometimes we're talking about clinical trials where there might be some element of the treatment that's offered that is experimental. And so make sure that you are ready to ask about all of the treatment options and ask the question, is there anything else that's available? And if the answer is no, then that might be an opportunity to consider whether or not you might want to get a second opinion. Please know, I've had patients tell me before, oh, I didn't want to hurt my doctor's feelings by going to get a second opinion. Please know that I've never been offended by somebody that gets a second opinion, because the truth is, if there's something else somewhere else, I want what's best for the patient. And if there's some clinical trial that is available elsewhere that's not available at my place, that gives me the opportunity to say, hey, let me look at that trial. Maybe that's something that we should be offering here. Or if that second opinion says, no, I agree with what Dr. Porter told you already, that also provides another reassurance because we're talking about serious stuff. And so it is well within your purview to consider second opinion. And there are lots of places now that offer virtual second opinions. So do look into what the treatment options are. And along with the treatment options, please understand what the side effects are. And so very important to know, and I'll just plant this seed here. I recognize that many people are interested in natural or holistic treatments. And so oftentimes I'll tell my patients that, if they're on a clinical trial, oftentimes we have to limit if they're taking anything else. But if you're interested in a natural or holistic treatment, please know that just because it's natural or holistic doesn't mean that it's not toxic. And so it's incredibly important to also ask the naturopath or the other doctors that you might be seeing or care providers that you might be seeing, what are the side effects from whatever natural therapy? And it's even better when they're willing to work directly with your oncologist or neurologist just to make sure there's nothing that's going to be antagonistic or work against what you're being prescribed on the other side. So again, the takeaway from that is, yes, we know that there are side effects with some of the more traditional Western medicine. These are all drugs that have gone through scrutiny and have data behind them. And so we've got those lists of side effects readily available to us. We don't have as much data on the natural or holistic side. So please feel empowered to ask about side effects in that regard as well. Important to understand what the expected outcome is from whatever treatment. And so that can help empower you to say, well, if we're talking about I'll use an example from glioblastoma literature, where Avastin or bevacizumab has been showed to extend the time of progression-free survival, meaning extend the time where there's no active disease, but may not as significantly impact overall survival with glioblastoma. It's very important to understand why the doctor is recommending that as the next best step, if it might help your quality of life or if it might subject you to additional side effects. And then the last sort of bucket or theme that you should be asking your provider when it comes to recurrence is what sorts of support services are available in your area or how you might be able to get plugged in because we recognize that needs differ. And so sometimes if you're participating in a trial or you're receiving a treatment that requires more office visits, maybe transportation becomes part of a challenge, or maybe as part we recognize with brain tumor diagnoses for many people, there's significant financial toxicity that goes along and is part of included as part of this journey. And so please know, particularly within academic cancer centers, there are support resources. And so very important to ask those questions as well. And so while you're getting sort of that education, I would be remiss if I didn't mention that there are significant emotional and psychological needs that can come about as part of the recurrence. I have a patient who is a writer. And she describes her experience so beautifully. And she coined a term that I tell her that I refer to quite frequently, and she calls it scanxiety. And scanxiety, in her experience, is this rumbling anxiety that starts the moment that it pops up on her patient portal that she's got an MRI scheduled, peaks in the days prior to the MRI, where she starts having even some physical symptoms that she may not have had before. And then doesn't start to improve until after our visit, when I've told her that things are stable and just fine, and she's halfway home. And so please know that this arc of the emotional response to the concern, even about recurrence, is real. And so there are some steps that you can take to be empowered to be able to adjust to some of those ups and downs. As you heard in the introduction, quality of life has been something that I've dedicated my career to. And so it's not lost on me that the most common concern I end up hearing from our patients is that they're concerned about becoming a burden one day. And while our appointment times often aren't long enough, I have done this long enough to know that oftentimes, while my attention may be right on the patient, the caregiver often is overlooked. And so I have really dedicated a lot of my work and research into figuring out how we can meet the needs of the patients and the caregivers who are so critically important in this journey to the best of our ability with the limitations that surround healthcare right now. And so recognizing that there's some important things that we have to be able to address in our time together, like symptoms and treatments and how we're adjusting to any disability that may have come up as a result of the primary tumor or recurrent tumor, and how the family and the support system is navigating all of this. And so out of this desire to help empower our patients and educate our patients, I joined in with a colleague, Dr. Lynn Taylor. She's up in Seattle, and we had a non-science writer help us smooth out some of the medical talk. Her name is Diane Richard, and so we published this book, Navigating Life with a Brain Tumor, really to be a supplement to the time that is spent together in the office, recognizing that it's impossible for us to cover in the time together everything that needs to be addressed. And also, there are questions and concerns that come up at night and on weekends. And I recognize the natural history is to go to Dr. Google, and now it's Dr. Chat GPT, right? And then the risk is that we could spend our time the next time we have an appointment together sort of unlearning all of the things that Chat GPT told you that maybe was not as appropriate for your exact tumor type. And so through the chapters in this book, you'll see that we really try to tailor it to match the patient's journey. So we start with a chapter called Where Do I Begin? And this is where we kind of take a look inside of your brain and understand what the diagnosis means and what radiation therapy is. And then we delve a little bit deeper in terms of how do I deal with this, lifestyle management, symptom control, care of the caregiver, how to plan for the future. And then we get more specific based on the tumor type in a section called What Can I and My Medical Team Do About It? And that's where you'll find more about benign brain tumors or primary brain tumors versus metastatic brain tumors and malignant brain tumors. And so again, we live in an information-rich society, but really important that we fill ourselves with information that is empowering. And there are so many barriers that we're looking to try to overcome, time being the most. And so just know that, resources like ABTA and the wonderful information that they've got through their website is a wonderful way to help empower your family members, friends, folks that care about the journey. When people ask, what can I do? Maybe they could learn a little bit as one of the tangible steps, but just please know that time ends up being a significant barrier in the office visit. And so we want to use that time in the most precious way that we can. One of the things that I am pleased that in my career time, I've seen a shift in is the acceptance of what historically has been called palliative care. And so when we talk about palliative care, sometimes people think that what we're talking about is hospice. And that's can be one portion of palliative care, but there really is a spectrum of care that we're talking about when we use the term palliative care. On one end of the spectrum is supportive care. This is early intervention, that kind of supportive care that helps manage the symptoms that you may be experiencing as part of your treatment. And then there's a kind of end of life care. And so that might be the next sort of phase. If you've had multiple recurrences and the doctor is saying, unfortunately, we don't have any additional, cancer-directed therapy options for you, all the way to hospice care, which is sort of very end of life. And so there's a range when we're talking about palliative care, not just the very end when death is imminent within days. And so what I've been pleased to see within my career time is an earlier adoption of supportive care, earlier adoption of palliative care, because we recognize that alongside of the neuro-oncologic care you're receiving, that that having someone who's paying attention specifically to the quality of life and the symptom control only adds to the experience. One of the challenges now with supportive care or palliative care is this is a specialty that is grossly under-resourced. And I recognize that across the country, there are some places that don't have the range of palliative care resources, as I am as fortunate to have living in a large metropolitan city. And so one of the things that we look to do with some of the research is to figure out how we might figure out the next best thing through technology, addressing some of the issues that come up for our patients and their caregivers, recognizing, and the patient population that we studied were those with high-grade glioma, recognizing that oftentimes those patients have unique needs that are different than those patients who have metastatic cancer. And because of the significant morbidity, meaning the neurologic deficits that can go along with having a malignant brain tumor, caregivers end up playing a different role than caregivers of someone who may have a lung cancer or breast cancer, as example. And so we wanted to be able to address not only the needs of the patients, but also the needs of the caregiver. And so we developed this tool that is kind of like an app that was on a tablet. And patients could, they ultimately would be able to click on some of the different things that were raising more concern for them in that day. Again, this is something that they would do before their visit, with an idea that once we got in the office together, I could spend more time speaking specifically to any one of these issues. And also, there was a way that we could print out additional resources based on where patients might need more intervention. And so what we did is we had a patient who had a brain tumor and their caregiver. They got randomized, so meaning they ended up participating in one of three arms of this trial. Either they just had a visit with me and had, or one of my colleagues, and had a basic survey, just a paper survey. Another group had the visit with me plus, or my colleagues, and plus using that tool. And then the last had the visit with me, the tool, and they got to see a palliative care specialist or a symptom management specialist. And what you'll see in these graphs in terms of overall quality of life, the control group actually was deficient for overall quality of life. But those people who had access to that iPad tool, so the group A, they had a much better quality of life. But the people that had the best or the highest quality of life were those who ended up being able to leverage the tool and have the palliative care provider. So ultimately, what this showed us is that even though there's that we know that having a palliative care provider ends up really maximizing how well we're able to care for patients, not just with their primary brain tumor, but also with recurrence. We also knew that we need to come up with creative ways to be able to scale some of the interventions and some of the ways we're able to help. And the other thing that was important learning from this research was that there were different concerns between the patients and their caregivers each visit. So you've got V1, V2, V3, visit 1, visit 2, visit 3, where work might have been the first concern for the patient, treatment was the first concern for the caregiver, and vice versa. So this was also helpful for our teams to be able to know where we needed to spend a little bit more time with the patients and where we needed to spend a little bit more time with the caregivers. Transitioning just a little bit to having some of these conversations that are emotionally charged. And so I wanted to share a little bit with you about some of the science behind what you might be feeling when you are experiencing that anxiety and sitting in front of the provider waiting to figure out, is this the day that Dr. Porter is going to share with me that the tumor is back? Um, Please know that when we talk about sort of this action potential of emotion, time point zero is when you're sitting in the office and waiting for me to walk in. And then I hope that in time I've learned to navigate this sort of emotional peak that patients experience with more finesse. But once you hear that it looks like the tumor is regrowing or we've got activity after having a point of stability, recognize that your emotions are charged up high. And if I were to data dump now and talk to you about all the things that I mentioned before that you should ask me about treatment and side effects and options and support services, if I tried very hard to tell you all that stuff after you've had this peak of emotion, you're really not going to hear or remember anything that I'm saying. And so instead, as I've had the real privilege of teaching our medical students and residents and fellows over the years, what I've encouraged them to do is share the sort of bad, sad, or unexpected news, and then just listen. And sometimes the listening also means silence. Because it just takes some time to diffuse all of that emotion. And please know, just as you all are experiencing this action potential spike of emotion, the physician also is experiencing that. And having that time to acknowledge that this is news that I hoped I'd never have to give and news that I know that you hoped you would never have to hear, taking that time to normalize before the data dump, taking that time to really partner with the patient and with the family members, with the caregivers, to offer that support and normalize the emotions that they're feeling, offer the tissue, offering the comfort of, a hand on a hand, whatever it looks like with the relationship that you've had with your provider. That's what should happen after the shock of what the challenging news is. And then from there, once things have settled a bit more, that's when more content can be given. That's where more questions could be asked. But always know that sometimes this action potential, even though it looks like it's, real smooth, sometimes that can last even days. And so there are absolutely times when I have brought patients back, the next day, a couple of days later, or we've had a video visit when they're back home, because then is the time to really receive more of the information. And I've spent more of the time within the office comforting. And so do know that we recognize that there's a lot of emotional transference that happens in our appointments. And so the onus is really on the care provider, though, to care for you during those visits. And one of the things that oftentimes can be kind of a bad, sad, or unexpected news is prognosis. And I shared in the very beginning that it's important to me that prognosis is an active and ongoing discussion. It's not something that I talk about only once. It's something that is revisited because sometimes our priorities change throughout the journey. And it can really help us prioritize sort of what our goals are. And when there's a difference between what the caregiver might be thinking in terms of priority, what the patient is thinking in terms of priority, that can lead to significant stress and discordance. And so this is something else that we looked at for patients with glioma, asking about their understanding of prognosis. And one of the things that I just wanted you to take away from this when we looked at patients and caregivers, there's a real difference between what the patient understands, what the caregiver understands, And however, when you're looking at the providers, the thoughts are often very similar. So what these results I hope that you'll take away from is the onus is on the care provider to communicate as clearly as we can, but also know as a patient and the caregiver, you also are empowered to ask those important questions and hold space for that conversation too, because it's really important that everybody has the same understanding. And so we've talked about the emotional impact. And so there can be a feeling of grief or loss, anxiety, depression, different feelings that come up. And so for us to, as the care team, to recognize that and support through it is part of our responsibility. We also know that when you're met with the concern of recurrence, this can have a significant impact on caregivers and loved ones. And so we can't underestimate and separate the stress and emotional strain from our overall well-being. And there's an impact when we're talking about the uncertainty of what might happen in the future. And so having your team of support ends up where you really have to lean during those times of uncertainty. And so in the last couple of minutes here, we'll talk about some mechanisms that are important to help us try to adjust and develop some resilience when we hear this bad, sad, or unexpected news of recurrence. And I am not, I put on the slide maintaining hope, and I would say that hope looks a little bit different for each of us. And sometimes I just had a conversation last week with someone about choosing to shift our focus from being as aggressive as we can as it pertains to the cancer-directed therapy, shifting that focus to then being as aggressive as we can with however much quality of life remains. And so when we're talking about maintaining hope, it's not always the hope that we are going to live forever. Because last I checked, none of us really gets out of here alive, right? But the hope in that we're able to reduce pain or make symptoms better or come up with a plan. It really does look a little bit different for each of us. And so just recognizing there's always something that we can be hopeful about. There's always something that we can be thankful for. And so, as we talk about some techniques for managing stress and anxiety, you can certainly go to your favorite AI, whether it's Chat GPT or even Google. You'll find different tools and different exercises that might be helpful for you. I'll tell you that for those that are able, moving your body is an important and effective way of managing stress and anxiety. Even if it's just kind of a wiggle or a shaking it out, getting the blood flowing, shaking out the stress of the tense muscles, recognizing that one of the things that I even find useful in my own daily habits, sometimes unbeknownst to me, just because of the stress of the day, I might start the day with my shoulders down here, but I realize by lunchtime I'm up here. Doing a physical kind of maneuver of up and down and shaking my shoulders around just to move a little bit. Sometimes that can break up some of the tension within the body. Mindfulness is an important practice, and it's something that you can really do with all levels of mobility. And so mainly it's calming yourself and focusing your attention enough to be able to notice the things immediately surrounding you and the sounds immediately surrounding you, the smells. And what that does is helps distract the brain from that action potential that we talked about and bring a sense of peace. So for some people, they find writing is relaxing. For others, drawing or painting is relaxing. Whether there's opportunities to use some apps like Headspace, where you can have a guided meditation These are all different techniques. You have to find what works for you. The one that you use is what's best for you. So please don't feel, I've got a picture of somebody here meditating and doing yoga. If that's not your speed, don't force yourself. That's not, my intention here is not to be a one size fits all, but hopefully to help you start to think about what areas might be better for you. And, people find relaxation in different activities. It's not always just laying passively. And just know for some people, being outside, going for a walk, all of that could be very relaxing as well. Whatever you find that works for you, develop a routine, establish a daily practice, and make it a priority in your life that that it's at the top of your mind, that this is something that you're doing to take care of yourself. And just as you would prioritize a doctor's appointment, prioritize this mindfulness or relaxation practice as well. Know that you're not alone. So there are several different outlets in terms of support groups or counseling. The ABTA also has a support group for adolescent young adults. So please know that there are resources where you can get some of those feelings out and discuss sort of what happened in the context of where you are in your journey, because sometimes getting it out of your mouth or onto a piece of paper, oftentimes that can be very therapeutic as well, rather than holding it all in. And then recognizing that having some open conversations with your family members and with those that are part of your care team in an honest way is critically important. I showed you the data where patients and caregivers are not always on the same page about where they are in the journey. So being able to create space for that open and honest dialogue ends up being with the stakeholders is critically important. Not only is it empowering so that everyone can share in the journey together, but also it helps people prioritize. It helps everyone advocate on your behalf, and it helps make people make you even closer among your support community. And while I recognize the desire is not to be a burden, please know I'm speaking specifically to the patients now, please know that the people that have offered and want to stand by you, they want to help. They want to hear when you have concerns. They want to know how they may be able to support you. So being willing to have that open and honest dialogue ends up being critically important. And so I'll leave you with a quote as we end sort of the more formal time together and open up for questions and answers. The responsibility is bi-directional when it comes to how we navigate this tumor journey together. And I would say that your healthcare team should own that large burden of responsibility. And there are resources and skills and things that we've all been taught to be able to help you navigate in what we hope would be a seamless way. But please know that through some of the tools that we talked about today, you also are empowered. And it's important that you get your questions answered. And it's important that you know what your options are. But still, at the end of the day, even in however, whether it's a 30-minute visit, a 15-minute visit, a phone call, I always keep in mind that people won't necessarily remember what I said or did. You all may not remember what I said or did in these last 35, 40 minutes, but certainly people will always remember how you made them feel. And so I hope that within this time that we've shared together, I hope that I've made you feel validated. I hope that you have felt empowered by having some additional information, some additional data that you can take with you in case you should deal with recurrence in the future. And for all of the caregivers, I hope that I've made you feel seen and heard, and again, empowered through sharing some of this information. So with that, Bree, I will end our slideshow, and then I'm happy to answer any questions if they've come up. Thank you so much for your kind attention.
Yeah, absolutely. Thank you, Dr. Porter, for all the wonderful information you shared. I've been over here typing away different takeaways. I especially really appreciate all the really tangible insights that you shared. I'm thinking about like the top to toe list of questions that you mentioned early on, to look for in terms of symptoms and questions to ask your provider. And I've seen questions come in through the chat, so we will get to those in just a moment. I do want to, if you've got more, keep adding them to the Q&A for sure. I do want to just really quickly before, because I know we're at the getting close to the top of the hour, and some people might have things they need to go to. I just want to share really quickly that we are going to continue this conversation, and I want to invite everyone to keep the conversation going in our Ask the Expert event that Dr. Porter is going to join us for in our Connections community. That post is live in our community as we speak right now, so you can scan the QR code on your screen using the camera on your mobile device, or visit the link listed below that QR code right now. I'm going to leave this up for just a moment while you capture that information. And like I said, Dr. Porter is going to be joining us there to continue answering questions that we don't get to today. And I hope you'll head over there not only to ask your questions, but to share your takeaways from today's webinar. And I will come back to this slide as well when we close out. So if you didn't get it right away, no worries. Dr. Porter, one of the questions that came through was, how can we help family members who may be in denial about their recurrence?
Yeah, that's a hard one. And I would say that meeting people where they are might be the first step. So I've had some circumstances where maybe the patient wasn't ready to hear about what the prognosis is in that particular visit. And I always start by asking the patient, because I'll tell you, sometimes I'll have visits and the caregiver or somebody else in the room is very eager and the patient's not yet ready. And so I take my cue from the patient first, because that's who I have the primary obligation from. And I ask the question, is this something that you're ready to hear today, or should we save it for the next visit? And then I bring it up at the next visit if that's what they've offered for. There are some cultures where it is more appropriate to have discussions with part of the family that may not necessarily include the patient. And so I do try to understand if there are some cultural nuances that I need to be sensitive to. But I always, as much as I can, have conversations with the patient present so that we can all understand together. And again, revisit it, recognizing this is not a one and done conversation. Please, let's continue to talk about it. Ask. I tell people, I don't have a good poker face. You'll know when I'm not happy about how things are going, and you'll know when I'm pleased as well. And so it's something that I try very much to normalize. But understanding why someone might be in denial, or and really understanding if it's that they're just not ready, I think is a bit of a difference. And the other piece that I always share when it comes to prognosis is I share that, you know, the numbers or the statistics that I give are really most important for those people that are writing clinical trials and writing book chapters and all of that. You are you. And so only you are going to write this story. And I would be lying if I knew exactly how much time any one of us has. But what I do share with people is that typically the diagnosis itself is the biggest surprise that we get in this journey. And each time we have an MRI, we'll have an understanding of where we stand. Each visit we have, and we do the clinical exam, and I'm seeing how well you're feeling. We'll have a sense of where we stand with things. So I try to ease the conversation in that regard, recognizing that those are statistics and that's based on averages. But with any average, there's a bell-shaped curve, and so there's people that have potentially have a much shorter overall survival, and those patients that have much longer. And part of our jobs are to try to make however much time we have as good as it can be.
Yeah, absolutely. And I think we've got time for maybe one more question, which actually dovetails right off on what you just shared in terms of treatment effectiveness. And specifically with the recurrence, do you see that treatment with a recurrence is more effective, less effective, about the same? What are you seeing on that front?
Yeah, it really depends on the tumor type and it depends on the type of intervention that's offered. So there are some instances where I've had a patient with a meningioma who they've had a second surgery because of their recurrence, and it's done very well for years and years. I've had other patients who have had malignant gliomas, like a glioblastoma, as an example, and we've seen growth even through their initial radiation, and have had a hard time trying to find a treatment that slows the growth trajectory of their cancer. So it really does vary on the tumor type and the type of treatment offered.
Mm, yeah, that absolutely makes sense. Well, thank you so much again for joining us and for graciously sharing not only your time but your expertise. I know I'm walking away with a lot, and I imagine our attendees will as well. As I mentioned in the beginning, everyone is going to receive a link to the recording and a follow-up email. You're also going to get the slides that Dr. Porter shared, and several of you asked about where to purchase her book. And that will be a third thing that comes in the follow-up email is a bonus resource guide. And one of the links in that resource guide is directly to purchase her book if that's something that's of interest to you as well. As I mentioned already, we will be jumping over to our online connections community to continue this conversation. Dr. Porter will be joining us there as well. We want to hear your main takeaways, and I'm going to be going over there too to share mine and help facilitate the questions and whatnot there. We also want to hear from you. Like I said in the beginning, your feedback is not only helpful to Dr. Porter as the speaker, but it also helps the ABTA, our team, in future programming efforts, even beyond these webinars. So we're all ears on anything you'd like to share. You can scan that QR code or visit that link on your screen. I'm also dropping this link into the chat as well so that you can have easy access to it there. And as soon as I can find the chat, I will actually. There we go. Got it. Um, and then there we go. There's the link to the chat there. It should only take about 10 minutes of your time at the most. And it really does help us out a lot. In terms of upcoming events. So next week, February 4th, we will be having our second virtual meetup of the year for our adolescent and young adult group, where we will be discussing dating with a brain tumor just in time for Valentine's Day. So this is a monthly virtual meetup for brain tumor patients between the ages of 18 and 39. And once you register once, you're registered for them all. So no need to do it every single month. Our next webinar is set for February 17th with Dr. Kelly Braun. Dr. Braun is going to be presenting on returning to work after a brain tumor, and we're really, really looking forward to it. We're in the planning stages right now, and I'm really excited with what's coming together for that. So if you or someone you know is interested in either or both of these events, you can find out more and register at abta.org. If you're looking for other resources that we haven't mentioned here, our website is what has a wealth of resources on it. You can go to abta.org. You can also email us at info@abta.org or call the care line at 800-886-2282, and our team will help you out and give you that personalized support as well. Thank you again to Dr. Porter for a great webinar. Thank you so, so much. It's been such a treat getting to know you. And a special thank you to each and every one of you for joining us today. We hope you found this information useful and make it a great day.